Hi, Dr. Sushil. It is a pleasure to meet you again. We have been meeting each other in various forums and also some WhatsApp group that we have where we share ideas. So I mean, it's a great opportunity now to talk about the newer things that is happening in healthcare, primarily from a patient experience perspective. And there are new buzzwords coming out, patient experience 2.0, how to build a connected, contactless, and a convenient hospital journey. So I'm keen to know. So if you look at AIIMS is primarily into public health and where the volume should be in thousands, if I'm not
Yeah.
mistaken. So, in those areas, how do you see this shift of patient experience going? And also, how do you define that in the next level of digitization or the patient experience uh, and this transformation? Number one, what is the expectations that you have from the patients? And then, how do you have a difference of doing the same thing in AIIMS, let's say in AIIMS Delhi vis-a-vis AIIMS Haridwar vis-a-vis AIIMS Devghar, which is a tier one, tier two, and tier three city. I'd be very keen to know that.
Yeah, first you have to understand that there is a lot of aims around the country, and all the aims are they work autonomous and independently. No one is connected each other. Okay, because of why this is, the government has thought that AIMS Delhi has a successful project, so similar kind of project will be transformed to some other states. So they have planned that all the states supposed to have at least one AIMS type institute. This is AIMS type institutes. So that's why it has come up, because you know it, in India we have 1:1700 patients, the doctor ratio and the patient ratio if we talk about it, and as per the WHO it is 1:400. So this is the big gap we have, and we get a lot of loads of the patients, around 17,000 say patient a day in one place where we have to give it treatment. And definitely patient journey is a big challenge. What we have observed, the demand what we are capturing, not even it is one third of the demands. So means the 17,000 means we need at least more than 50,000 demands are there. So first patient experience when it will come, whether I am going to the AIMS based on my merits, I am getting the treatment or not. Because you know demand and supply is gap is there. There is a third party inside who can manipulate it and give the registration appointment in backdoor method. So that is the first kind of experience patient they feel. That's why it has been made totally online. Whatever it is there, nothing can be done out of the way. Patient take the appointments or patient come in the hospitals, same day they can do the registrations based on the first come first service basis. So this is one thing, it has been done completely online. They can do the appointments through our call center or apps or our own URLs, and on that day come and show to the doctors. The major
Okay.
issue is that the experience is that whether you are getting a doctors on time or not. Second part is that how the patients will be facilitated. Let's a lot of patients are coming, they need wheelchair. That much wheelchair is available or not. They need stretcher. That much stretcher is required or not, and how they will be given. How to the wheelchair and the stretcher is to manage. It's a big challenge. All these things it has been online, so the experience has been gone up by the patients very high.
You said is absolutely making a lot of sense. And when we talk about volumes of in the magnitude of 17,000 to 20,000 OPDs or patients in a day, that would be significant as compared to any private hospital. Do you think that there is an issue here? And I'll also give a perspective more from a private hospital that I come from, or I have the experience working with. So, is that in a public hospitals, the patient is not paying. vis-a-vis in private hospital, because patients are paying, they feel that there has to be a value to the time, uh, and there is a sense of entitlement. uh, I mean, if I'm paying at 2000 rupees for a consultation, then I mean, why should I wait? Why can't you do this pre-registration bit online itself so that my time is saved? Why do I need to come looking for my lab reports? Why can't this prescription be online? Because there's a sense of entitlement because I'm buying the service. I'm paying you for this. So from that perspective, it is, I mean, generally what I have seen in a private healthcare is that it's about designing a connected system where it is frictionless. All the various department, they need to talk to each other, and that is where essentially means giving a seamless patient experience, uh, which is from a convenience perspective, from a transparency perspective, and continuity perspective. So, from a public healthcare, do you think because the patient is not paying, the sense of entitlement comes down, or the expectation is still the same?
The expectation is still same. That's why those who are coming to the OPD, same day they can do the investigation, and by evening they will get the investigation from their own mobile. They can download it because the second visit is not required, because giving a sample for next day and again it will come, it is not. Some of the places what we have done it, same day they can show it also. In our cancer in Jhajjar, if you are coming in the morning, showing to the doctor, whatever investigation, even MRI, CT, everything should be prepared, and by 3 o'clock, everything is prepared. So you can, after the investigations, reporting, you can see it, you can show it, and go back. So this is the means we have made the same day life cycle for the patient to complete their whole treatment process in single day. There a lot of other things are there. And simultaneously, they can plan out that any appointments is required, then they can give it, and they can come in the next day. This is what I'm talking about the outpatients. What about
Okay.
the patients, those who are admitted in the hospital, the inpatients? Okay, the inpatient's journey it's supposed to be very smooth. If it is smooth, then the patients they can feel have a uh, good feeling that we have come to a hospitals and everything is online. When we are talking about the whole patient's journey in the inpatient, we admit around 700 patient in a day in the hospitals. And what we have done it in single window system we have created. Okay, your bed allotments means the basic because you take charge very less, so the payments everything it will be done in the same locations where the patient is going to be admitted.
Okay.
So
Okay.
yeah, and simultaneously when he is admitted, the health workers they inform that now you are in our custody, everything's our responsibility. If the blood collection is required, reporting is required, everything is automatic, so the things it will be done. And simultaneously the discharge what it happens uh, when we talk about the discharge of that, uh, it takes a lot of time for discharge summary, because the junior resident has to prepare a discharge summary, then senior resident validate it, and the consultant will approve it. This process, if the patient is admitted for 10 days, at least it takes 2 to 3 hours for each patient, and it is very time consuming. So that's why many AI tools it has been used, and the process time it has gone down. And 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 the patients, let's take, doctor has decided in the round that the patient has to be discharged, so within half an hour the discharge summary and everything is ready with them.
Okay.
And what
Brilliant.
are, yeah, so that life
Yeah.
cycle has gone down drastically as compared to the earlier systems.
Okay, perfect.
But
Dr.
yes.
Sushil, you spoke about availability of the information on the mobile apps. You also spoke about using
Mm.
digital tools for generating discharge summaries because that is the perennial delay of discharge summary, and all hospitals are having
Mm.
this across public health and private healthcare. So, And what do you think when a hospital aims to build a seamless, contactless journey from registration to discharge? Where do most institutions actually get stuck? Is it because of the technology? Is it about the clinical adoption? Is it about the workflow design, or is it about the cultural readiness? I'll tell you before this, what I understand is one of the challenges that I see is I read a quote somewhere that generally when any hospital is looking for a digital maturity, they often try to implement a system which is digital, but their workflows is always is analog. So
Yeah,
when
yeah, yeah.
it's about people, process, technology coming together, it's about clinical adoption, it's about change management or the behavioral change management. And plus, I mean, even if you're implementing a solution in a department, it can't be just remain in that silo. It has to be a cross-departmental alignment is very important to make it a success. And technology is just a technology that it has to be ultimately be amalgamated into the process to be used by the people. So I feel generally in a private hospital, culture plays a very significant role. Unless clinicians, nurses, frontline workers, they actually see a value in this, the digital journeys always remain fragmented. And despite having right tools, it becomes very difficult to implement any solution. What is your experience about it?
You are very much right, but digital adaptation by the AIIMS, it is quite long time. Okay, first digital adaptation, it has started in 1988. So that's why the culture has already been there. And second part is that AIIMS is an institute for the healthcare research and education. When you do any research in healthcare, you need the patient data. So that's why the consultant without patient data, he can't do the research. And research is the first objective. Doing the research, you need the healthcare services. That's why the hospital is there. So that's why each and every consultant, they want to acquire the maximum data, and that's why already the culture is there, and the adaptations automatically it follow it. Second part is that when the patient is there, you have made a workflow in such a way they have to come into that process. Okay, without that process, it will not move. When the patient has been already been shown in the in the OPD, all the OPD data will transfer to the inpatient automatically. And when doctor will come, everything it is on the screen. Okay, so it is not required to make a clinical notes on that. All the clinical notes is ready for him. Just you have to start the new notes on it. So they feel that it is quite easy for them to do it. Second part is that all clinical investigations it will fetch automatically. And the system is that if the you need a urgent any test and it has been performed, automatically the SMS will go to the doctors that this test which you ordered and it's urgent, it is already been means ready, and you can look into the patient profile, so you can get it. So when things are coming in this way, they feel more easy to work for it, and that's why we do not feel any problems. But you are right, the people, process and technology is a major importance factor. Still we have because new generations, it is very fast, they are adopting. Old generation, still it is stigma is there, but situation as such, they cannot go out of that.
I mean, yeah, so I will ask the this question and then I'll look up to you to set up the next question. So, I mean, what I've seen and what you have also mentioned that it's about making that all the various departments come and start talking to each other,
Mm,
whether we are doing for patient experience, whether doing for
mm,
research, or whether we are doing for providing any services. So,
mhm,
connected care actually requires systems to talk to each other. It cannot operate in a silo. So
mhm.
from your experience, what is the most critical interoperability layers in a hospital? And what they must be get it right in the first instance, whether it's clinical records, IoT devices, command centers, mobile apps, or anything of that sort. What do you think that the hospital, which are the most critical interoperable layers for a hospital?
See, when you are going for a clinical informatics, in that cases, your metadata will be standardized. If the metadata is not standardized, the data it cannot move. Another clinical notes when you are writing, when clinical quotes will be standardized. So uniformly it will be there. That culture it takes a lot of time, lot of education, because Nomad City, no hardly any hospital they adopted it. But AIMS has already been
True.
adopted as Nomad City. Okay. People say
And
they're
government has
adopted.
taken a license also for Snowmed
Yeah,
City. So
yeah,
no
yeah,
hospital needs to actually buy any license for it. But still, in private hospital, at least I
yeah,
have not seen any hospital except one which they use it only for the surgeries. They don't
yeah,
use it for anything else.
yeah. Basically, see, Snowmed City implementations for the around the country, I was the nodal person for it.
Ah, okay.
Content nodal person for this for 5 years. Uh, anyway, that is a separate things. But thing is that it what the people feel it that it takes time to enter the clinical notes, and that is they are hesitating because those who are in a revenue model in that cases, why doctors time will waste on these things. But in AIMS part, if you talk about it, they need they are hunger on data. Okay. And the already the culture is there, more data, more healthcare, more data, more health research. That's why everybody they hunger about the data. And when today's you know it, because right now it is a era of AI. So people have already started adapting it. So you need the data quality, data standardizations, then integrations is very easy. People are using it. Many APIs are available in-house. People are developing it. Many tools are there. Very fast API can be it can be developed and it can be integrated. But simultaneously, if we talk about that, the how device will be integrated. Okay, this is my experience. What I am sharing it. When my one devices has to be integrated to my network, we face the problems. We do not have any IoT devices in the market. Then I have gone through the different journals and the study. Then I came to know that there is one device is an open source device. It is called Raspberry Pi.
Raspberry Pi, correct.
Okay. And we
Yeah.
have purchased Raspberry Pi from the Amazon. We have purchased that one, and we have tried to a one Elijah based lab equipments, that how to integrate it. This is the one-way communications. And first we have tested in a TV. Okay, earlier the TV was not available smart TV. We have made the TV smart using the Raspberry Pi. Then we have started to using in the laboratory equipments. I can't believe it. We have succeeded. We have succeeded. So then we have started using in other devices. This is the first. It is about to be, you can say, 2005 2006. So right now majority of our equipments are integrated with the IoT devices, IoT devices, and it is working very seamlessly, because laboratory equipments people are doing in third party software. With here is the middleware is there, but IoT devices, because it is not required any third party servers to be integrated, so it is seamlessly using less power. We have developed one IoT device with the battery backup inside the device, and this is looks like a one smartphone, one bigger smartphone, that much of size, and it is
Oh,
catering very. Yeah. So that's why we have improved a lot in this angle. Second part is that recently we have installed the smart labs. Smart labs, this is the first kind of such type of labs we have installed in AIMS in 2020. This is the first installation in Asia, and it
okay.
caters per hour more than 15,000 tests. Okay, and that test, it is just you order it, then collect the sample, put in a tray, then everything is automated, and your the barcode has been scanned by the automatically the machine. Then he'll select that tubes, take by robotic hands. The robotic hand carry that tubes to the particular lab equipments. Automatically it will put it there. The test will be performed by that equipment. The result will fetch in the centralized data repository systems. And after fetching this one, the beauty is that we have analytic programs. Okay, that analytic programs, what will pull the data, that what medication is going on, what disease he has. what the past investigation reports, everything it will make the permutation combinations, and he'll give a signal that is supposed to be passed or is supposed to be
Okay.
re-examined. Yeah. So
Okay.
so so
Okay.
if it is green, generally the doctors feel that it will pass, so that the treating doctor they can say it. Means it has to be authorized by the lab consultant for the to the doctor to review, to see it. So this is totally
Okay.
automatic, this process, and
So
all our
this.
equipment is connected with the IoT devices.
Okay. 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 So, I mean, you spoke about the smart lab, and which is first in the Asia.
Mhm,
But if you look at the initiatives which are primarily from a patient engagement perspective, whether it is self check-in or smart queues or virtual follow-ups or discharge concierge, because we are seeing this because this touches the patients. Uh,
mhm,
and these are becoming pretty standards as far as private healthcare is concerned. Of course, these are all because these are all under the garb of patient experience.
mhm,
What do you think that from a private healthcare, which of these will yield the fastest patient experience and which requires deeper organization change before they show any value? So, more from a private healthcare, I think the online registrations, the appointment rescheduling, the smart queues, the digital payments, they actually deliver quick and visible patient experience because then I don't have to go and stand in the queue. So we have applications where the patients actually checks in from the mobile itself. If I've taken
mhm,
the appointment online, if I've done the payment online, I can check in online. Why do I need to go and stand in the queue? And then my name appears on the queue management. Uh, but if you look at the initiatives of virtual follow-ups or a telemedicine or
mhm,
teleconsultation or a digital concierge services or a care coordination, it is just not about the patient getting availing the services. It requires a deeper organizational change and also the coordination between various hospitals. Because if a teleconsultation, uh, a, a department needs to talk to and ensure the availability of the clinician at the right time, because clinician will not keep a track of themselves that someone is I'm supposed to get it online. uh, Many hospitals of ours actually have a teleconsultation room where they come in and all, so that requires a coordination between various departments. They also need a clinician buy-in, whether they would be okay to do it this or not. The care models needs to be redesigned, and the
yeah,
ownership needs to be there as to who is actually driving those initiatives. Otherwise, all these will remain just a technology initiative, but the features would be underutilized, and the experience will not be delivered. So, I mean, what do
mhm.
you think? Uh, I mean, these smarter initiatives, which has got the potential to give the biggest benefit?
Surjit, one thing is that first, for us, patient is the first. Okay. In that concept, what we have done it, how to empower the patient. Okay. So you need a digital transformations, and we have started the OPD because OPD has the major threshold for us. So what we have done it, let's take we have 17,000 slots in the OPD slots in the morning. We have categorized that 30, 30, 30, and 10. 30 means you do online, and healthcare is just such a thing, you need immediate doctor visit. So that 30%
Correct.
is there. Okay. Another 30% is the revisit people. Another 10% is any person has land up his very serious condition, immediate is required to be
Yeah.
treatment. So in that case, that 10% is there.
The
It
A&E,
is not.
primary accidents and emergencies.
Yeah, yeah. No, extended emergency is the separate. It is not part of that. Yeah. Okay.
Okay. Okay.
Because we have trauma center, they do the accidents, and the
Okay.
emergency department we get around 1,200 patient a day. That is separate. That is not a part of this
Okay.
because we
Okay.
can't deny these people. We can't deny these people. Those who will arrive.
Okay.
Yeah.
Yeah. Yeah.
So so this 30%, those who have already taken the appointment online, when they will arrive, they are not required to go to the any counter. Each locations we have put in the barcode. Scan the barcode. Then it will ask what is the appointment number. Then put the appointment number. Then all the field information it will pop up. Anything has to be changed, they can change it. After that, they have to fill rest of the informations automatically, and automatically mean he'll get the electronic OPD card. Okay. And if you want to take a printout, go to the counter, take the printout on one because you do not have the printer. Simultaneously, we have the kiosk around the OPD, and that kiosk also it is working for that also. The sticker will come up, then blank OPD card, you can paste it and go to the rooms, and room will be allocated automatically. Because let's say we have medicine department. In medicine departments, we have around more than around 40 rooms are there. 40 doctors they have seated there. So the room will be allocated. If you have the first visit, the new doctors will come up. If you have the second visit, in that or revisit, you can say, it will go to that doctor which you are getting the treatment. And the
Okay.
queue number, everything it will come up. When you go to that floor at that room, there is a screen in front of the room it is available, and the sequence number is there. Let's say you have the sequence number 7, so you can see where you are. Simultaneously, the patient experience what you are talking about it. Let's say somebody has the sequence number 35. It will give a message to you that it will take around 30 minutes. 30 minutes before it will not come, or 1 hour before it will not come. So he can go to the canteen, have a cup of tea, and come back.
Perfect. Perfect.
Okay, yeah. So that kind of experience means people have been given to them, and simultaneously, when the report will be generated, let's take you have done the tests and he came back. When the test is reports, the SMS will come to him that your report is generated. You can download.
Brilliant.
Yeah. So this kind of
Yeah.
means we have done the means empower to the patient to do it. Yeah.
Okay. Okay. My last question, Dr. Sushil, would be that as the hospitals they prepare for 2026, what should be the CIOs and CTOs prioritize to build a truly connected, convenient, and contactless patient journey? What are the capabilities, whether it's people, technology, or process, which will define the next leap?
See, after the COVID has given one of the vardhan, you can say, to us that people should adopt technology.
True.
Okay,
True.
yeah. And today's stage, what I feel in any domain across the domain in healthcare also, that everything's possible. The technology which is in the industry. You talk about AI, you talk about blockchain, you have talk about AR, VR, everything it is there. Okay, but where to apply, how to apply, you have to take a call on it. Let's take for us, if we get the budget, we raise the budget, we get the budgets, then we do it. For in your cases, what it will be that again you ROI play a major role. So what we are I am looking towards it. AI play a major role, but my experience, because last 20 years I am teaching AI to the post graduation students in AIIMS. I know in and out of what is the advantage of AI. But when you are using AI in patient healthcare services, you have to use very carefully. AI is not an application. AI is a model. Will assist you. What the human nature is there when they feel that AI is doing better than me and I have to rely on AI. In that cases, everything it will collapse. So that's why AI play a major role. Second part is you have
Okay.
to more careful that cyber security. Okay, because data is not the owned by the hospitals. The owner is itself patient.
The
When
patient
data is
themselves.
yeah
True.
yeah when data will leak, then the confidence level of the patient will go down, and that's why you have to more careful in the data how it can be kept securely.
Okay. So
Third thing is that now DPDP has come up, and you have to be more carefully when you are using the data. The data classifications is required. Data where you are keeping the data, that is also the data residency is also
consents also,
required.
withdrawal of consents and all from the
The role of
patients, all
consent or
those.
the consent is a bigger role. So we
Yeah.
take the consents because any treatment we take the consents, but right now it is mandatory. By default, you have to sign it. Earlier
Correct.
it was not there. Okay, so you have to sign it. So these sort of things is there. So right now the challenges will be the implementation of the DPDP and simultaneously the AI.
AI and
The,
cybersecurity is what you
yeah,
mentioned.
These
Yeah.
three things are most important right now. Yeah.
Yeah, yeah. So I mean, I think that apart from those things that you mentioned, rightly, AI is the new buzz where which actually improves the efficiency,
Mhm.
plus the cybersecurity and also implementation of DPDP. I think in 2026, whenever CIOs and CTOs are looking at solutions, they should not be looking at point solution. They should look at a platform because system have to work together. That would be what
Yeah.
I would say. Second, what I talk about is that they should look at experience driven workflows. I mean, it's not
Mhm.
about one particular, and it happens in private hospitals a lot where
Mhm.
a doctor who joins, he is influential, and then
Mhm.
you just to please because he has worked on some solution elsewhere that gets implemented, but the moment he leaves, I mean, again, everything comes back to zero. So that's what I say. So it's more about experience-driven workflows around patients and clinicians, not around departments. And then, of course, people and change management because technology alone it just can't transform. It's about people. So
Mhm.
yeah.
The major issue is that we saw all people supposed to work in a collaborative manner. Okay, collaborative in the sense each and other hospitals, it may not be a same chain hospitals. How data can be exchanged interoperable? That is the things to be taken care of by CIOs and CTO. Put the things in the CEO level. Okay,
Correct.
because right now the government has started using the ABHA ID. ABHA ID is meant for the data to empower patients, but that is not been done by the majority of the hospitals what I found. Okay, if ABHA ID is everybody they adopted it, the single medical records can be accessible by the itself the patients. Wherever you go, he can access it. And that is the one of the challenges in 2026 government is trying to push this one also. There three things are there. One is the AWA, again it is already there but they'll push it. Second part, cyber security. Third one is the AI has to be large scale people start adopting it. Fourth one is the DPDP. So these are the means what I feel in by 2026 major hospitals they will get a challenge on it. And I feel same things you also might be the challenge to you. And
Yeah.
the second part is that I'll tell DPDP in the healthcare uh, why it is challenge that many things it will not suit to us. Many things it will not suit to us because it has made for the manufacturing or finance or insurance. It is not totally made for the healthcare. So it will give a lot of impact in the healthcare. It is lot of amendment is required in healthcare.
But now
Let's see.
government has notified those the rules now, and they expect that within 18 months all the hospitals have to be onboarded. Uh, so
Yeah,
I mean, I don't know. But it's still people, the healthcare institutions are struggling to understand what is the impact and what are they supposed to do.
yeah. Everybody's blind. Uh, One thing is that when DPDP has come up, okay, right now it means gazetted notification is recently it has been done. You have to understand that the government will definitely give a workshop for us. Okay, they have to give a workshop for us. They'll take our grievances what to be done because you have to keep a DPO.
Yeah.
Yeah, and DPO system what it is there, what is his responsibility, what it will be clearly defined. So the government has to open up a one commission or something office, and they have to take the responsibility to implement the across the country. So let's see what it will happen. But everything is right now in the dark. Just it is your notifications, and you have to follow the notifications. How to that has to look into it.
Thank you,
Okay,
Dr.
Sujit,
Sushil.
we have a nice discussion with you, and uh, challenges are both from both the sides, not the public hospitals. In government also we are facing the same challenges is there. And third one is that before going that it is very difficult to get a trained manpower in healthcare who can really deliver the technology. That is the
True.
main thing. Yeah, yeah. And that is we have left out. Anything if you like to say to the audience, you can say also to give a message based on your experience.
No, I can only say if we look at the patient experience 2.0, we spoke about uh, people, process, and technology. We spoke about the interoperability and departments talking to each other. We spoke about faster wins versus deep transformations. Faster wins could be online registrations and all, but deeper wins could be making the underlying process automated so that it is even more convenient to the patients. We spoke about essential and nice to have technology in terms of, uh, I mean, how if any solution is actually reducing the patient friction or the staff cognitive load, and like you said, the private hospitals are more driven by return of investment. I mean, why am I investing this? So if there's anything which we can measure, then that becomes an essential technology that we'd want to implement. And in fact, experience transformation is now it's about decision enablement for the patients, not only visual sophistication. Like you spoke about that in the queue management, there's already a tentative time that will take for your slot to come. So if in that is about a decision that now patient can take look at that information and decide it that no, maybe I'll go for a cup of coffee and then I'll come back and stand in the queue. So those things, I mean, I think that's what will matter. The next year, of course, apart from AI and cybersecurity and
Yeah, yeah, yeah.
the ghost of DPDP, I think the challenges more would be more about implementing and onboarding more patient experience technologies.
Yeah, 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 yeah,
Uh,
yeah.
and the queue management, smart queue, kiosk, those are no more smart.
Yeah, 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 yeah.
That's given.
That is a legacy
So
system right now, right? Right now, that is a
yeah,
legacy
that
system. Yeah, yeah, yeah. Yeah.
true, true,
The technology has gone beyond the expectation right now. Just you have to see and adopt it based on your requirement and what the hospital policy. Anyway,
true,
nice to
true.
talk to you. We have
Absolute pleasure.
nice sessions and nice to meet you also and see you very soon,
Yeah,
physically
yeah.
or virtually, any one of that. Yeah.
Sure,
Okay.
Dr. Sushil.